systemic therapy in most of the patients. This will be my approach to treating the axilla today. We have to include ultrasound scan examinations for staging of the axilla, as it will reduce the pathological positivity rate after.
I have a few questions for the panel later on. I'll request Dr. Neha to please present intelligent vacuum-assisted breast biopsy to identify breast cancer patients with pathologically complete response after neoadjuvant chemotherapy. And they're trying to omit surgery completely. So,
thank you,
Dr. Neha.
Harit Chaturvedi sir, and thank you, team SABCS, for giving me this opportunity. So this is a very interesting abstract, and kudos to SABCS team for picking this small poster from the lot. This is the abstract is intelligent vacuum assisted biopsy to identify breast cancer patients with pathological complete response after neoadjuvant systemic treatment for omission of breast and axillary surgery. So I looked up the primary author, Andre Fob, here, and he is attached to Heidelberg University Hospital, Germany, and MD Anderson Cancer Center. And he's got a keen interest in artificial intelligence and breast cancer research, and has a lot of work going on. So a little bit of background, we all know that neoadjuvant systemic therapy does elicit pathological complete response anywhere between 40 to 70%, depending on the IHC. And these patients would probably benefit from no surgery, no breast surgery. And breast surgery is an over-treatment in them, but we do not know how to select this patient group. Currently, no approach, be it imaging-guided, vacuum-assisted biopsy only, has accurately detected and excluded residual disease. All of these have had a false negative rate of more than 10%. So now what have they done? They have taken help of machine. So machine learning algorithm was what they have done. They have trained, tested, and validated this machine learning algorithm on their previous trial, that is on the responder trial and subsequent trials, by putting patient imaging, tumor, and VAB variables, and then tried to detect whether the machine is able to detect residual cancer properly. So the algorithm, what they've used is XGBoost or extreme gradient tree boosting. I'll tell about it later. And they have tested, first they have had a developer set where they have tested 318 women with T1 to T3 disease, node positive or negative, and who could potentially respond to chemo. So HER2 positive, triple negative, or luminal B type. They have 10-fold cross-validated it for developing the algorithm, and again validated it on another independent trial, which was of 45 women. Then they have compared the histopathology with the final surgical specimen with the algorithm result. Their primary outcome was false negative rate compared to surgery and specificity. So a little bit about what XGBoost is. So this is a decision tree based algorithm where there are multiple options which the algorithm can choose. Further, in the parallel tree choosing there, and then they have selected subsets from that, build up a random forest, done boosting, that is minimized error, again done gradient boosting, again minimizing error, again they done extreme gradient boosting, that is tree pruning, minimizing errors, handled missing values, and finally developed the algorithm. So this is XGBoost for you. There's a lot to talk about it, but time is less. So if you just look at it, what XGBoost has done, so it has allotted impact or value to specific variables. For example, if you look, then cancer cell in VAB has a very high impact value. Obviously, that will be, and like a progesterone receptor or VAB size has a much lesser value. So finally, the result that they got in the development and the validation set was pretty good. The negative rate was 5.2 and 0% in the different sets, with a specificity between 37 to 40%. If we compare it to methods of imaging alone, VAB alone, or imaging plus VAB, we see that their false negative was very high, 24, 28, 12%, whereas for intelligent VAB, it is 0 to 5.2%. However, the specificity is 40%. So the authors have concluded that intelligent VAB can reliably exclude residual disease after neoadjuvant systemic therapy. And this can be evaluated in future trial for omission of breast and axillary surgery for exceptional responders. My take would be definitely this can be a basis for a randomized control trial to see further outcome data. However, if we do find a randomized control trial, what are we doing with radiation? Because when we conserve breast, we do add radiation to non-operated breast. Another thing is, if you see that the specificity is quite low. So out of 100 cases which have had a pathological complete response, they're able to pick up only 40. So, there's a very stringent criteria. They have a very high threshold of rejection, and that is why probably their false negative is so low. So can we expand criteria for patient selection to improve the specificity? What can we add? Can we add circulating tumor cells? Can we do subset analysis by IHC? If we look at practical world, again, availability of lab, training, skill, all those are things which have to be looked into. A little bit of food of thought, we are seeing something very amazing here, that artificial intelligence is helping us pick up cases which have responded excellently. So can we apply this to metastatic disease? On one end, we are looking at oligometastatic disease and local therapy, whereas other end, we are looking at local disease without local therapy. Can we find a middle ground? And again, we have all had patients who have been metastatic disease and have responded for long-term, 5 years, 6 years. Can we reclassify them as a better prognostic variable? Can we check circulating tumor cells, add it to algorithm and do something about it? So I think artificial intelligence has a long way to go, and there's still a lot coming up.
Thank you. Thank you, Dr. Neha. And I think this will invoke a lot of questions, and it certainly has given a lot of thought to people wherever they're listening. But we'll have a few questions on the panel. I'll request Dr. Vaishali